Good afternoon, everyone. Welcome to this session. Before we proceed, I'd like to invite Emma to take us through housekeeping. Thank you.
Great, thanks, Tawera. So if you've been in other sessions, you'll already have heard this, but just to emphasize that the event's a webinar format. So it means that only the panelists can share their microphones and video, and the rest of you are therefore muted. But to contribute to the discussion or to make a comment, you can use the chat box, which is in the right-hand side of the window. And you can also use the Q&A box to ask questions next to the chat box. But if you do want to make an oral contribution and ask a question in person, you can raise your hand and we'll invite you to come and speak. And we'll make some time for questions to be dealt with at the end of the session. And we also really value your feedback. So if you could participate in the polls at the end, that would be great. And just to say that no form of abusive or offensive language or behaviour will be tolerated in the chat boxes. So just to listen with respect, as I'm sure you all do, and be mindful of the experiences of others. Okay, thank you. Back to you, Tawera.
Thank you very much, Emma. To our participants, my name is Tawera Luhanga. I'm a trustee, the only non-health trustee of the Wales and Africa Health Links Network. The network supports and advocates for all partnerships between Wales and Africa that are involved in health activities. The network is a charity. All trustees are volunteers, and we rely on the tremendous support of the Hub Cymru Africa, here present. Emma is one of them, for the events like this, and they are very, very good at what they do. You can find out more about us on our website. I now have the pleasure of introducing to you Dr. Choolwe Jacobs from a country that I love very, very much for reasons to discuss next time. Dr. Jacobs is a public health specialist, an epidemiologist, and academician. She is currently working in the School of Public Health at the University of Zambia. She is also the country lead for Women in Global Health, the Zambia chapter. She has extensive experience in working on sexual, reproductive, maternal, newborn, child and adolescent health, nutrition, neglected tropical diseases, HIV/AIDS, and non-communicable diseases, with a focus on gender and health equity and implementation research. So Dr. Jacobs will talk about progress and challenges relating to maternal health in Zambia. But before she takes over the floor, I would like to encourage all of you to feel free to ask any questions using the Q&A that we have on the right of your screen. Now over to you, Dr. Jacobs.
Thank you so much, Tawera, and thank you so much to all that have joined in to listen to my presentation this afternoon. My greetings to all, wherever you are joining us from. Could be good morning, good afternoon, or good evening. It's my pleasure to present to you a topic that is on my heart. It keeps me awake at night to think about how women's health should be addressed and ensure that no woman is left behind. I will be presenting to you my slides, and we'll check with my colleague if he will or I should present. I should. So allow me to quickly. So Tawera, do you know if Thomas is zooming on my behalf? Okay. Great, thank you. So my presentation this afternoon from Zambia is on disparities in maternal health services in Zambia. I would like to share with you the progress that the country has made so far, including the challenges that we still face as a country. As I've been introduced already, my name is Choolwe Jacobs from the School of Public Health. I'm the country lead for Women in Global Health. So you can move to the next slide. So I thought I could share with you and just be clear where I'm coming from. So there we have Zambia. Zambia is at the bottom of Africa. So one of the attractive creations is the Victoria Falls. I live in Lusaka, the part that I've shown you. Lusaka is the capital city of Zambia. We can move to the next. So one of the other attractions we have for our natural resources, we do have, we have a lot of natural resources. Thomas, are you able to move to the next? Okay, so there we go. We interact with animals. We do have a lot of natural resources like elephants, lions. But I thought I could share one of our poets in Shima, and we eat it. It's a type of food. We call what we call relish. So I thought I should give you a background of who I am and what I eat. Well, is it okay? I could share slides from my end. Okay, I'll give a quick intro to my presentation, and would like to indicate that globally we have seen existing inequalities and inequities in regards to access and delivery of maternal and newborn health services, and these have continued to contribute significantly to the high morbidity and mortality that we see in regards to maternal mortality. And unfortunately, low and middle income countries are the most disadvantaged in regards to high morbidity and mortality for maternal, including newborn health outcomes. And one of the contributors to this, and one of the patterns that we see in this disease burden and outcomes that are occurring, are the disparities, where some regions are better than others. And also within countries, we are seeing that there are existing disparities in regards to the disease burden, to the outcomes, including to service utilization. Okay, we can move to the next. This slide provides us with the patterns that we see in regards to maternal mortality ratios. Can be seen as of 2014, you can see that the low and middle income countries are contributing more to maternal mortality, while in some regions, in some countries, especially developed countries, where no woman dies due to pregnancy-related causes or complications, we see the burden higher in some of the countries like low and middle income, for which Zambia is part, as can be seen here. The darker shades are the areas where there is higher mortality. Maternal mortality, as I've indicated, this is death of women during pregnancy or after, soon after, and this death is related to complications during childbirth or any pregnancy-related complications. And in regards to the share, if we move to the next slide. So for this slide, in regards to the share of women that are expected to die from pregnancy-related causes, again, you see the disparities that exist globally, where we see that most of the low and middle income, low resource areas, including Zambia, most of the parts within Africa, sub-Saharan region, and part of the southeast region, we see that these regions have the highest from pregnancy-related causes or complications. And this really demonstrates the disparities that are existing in regards to the health outcomes in relation to maternal health. So for the next slide, it's another way I'm trying to to show the share of newborns who die before reaching the disparities that are existing. We see that in regards to child mortality rates, the lighter, this is where we have the highest burden. So sub-Saharan Africa, including other low-resourced countries, have the highest or higher share of newborns that die before the age of 5. We can move to the next. So in regards to services, so most of these deaths and the burden that we are seeing with its inequalities, where some regions are better off compared to others, are related to the services that are being provided. And in regards to service provision, we see that there's been substantial healthcare disparities, including in provision of services between and across regions, including countries. And most times and historically, we know that rural communities have lower healthcare and clinical laboratories. They have higher levels of poverty and unemployment and longer travel times to some of the social services, such as some of the services that they require, such as healthcare services. Additionally, the lack of healthcare equity in sub-Saharan Africa that I've shown you is increasingly becoming a burden. And what I'm going to do in this presentation is to show you what's happening within Zambia. And then we can move to the next slide. So while we talk about disparities, and you may wonder why we need to talk about disparities, why we need to talk about issues of equity, because we need to talk about this because according to the Sustainable Development Goals, one of the key elements of the SDGs is to effectively mitigate inequalities and ensure that universal health coverage is essential, particularly to reproductive, maternal, newborn, and child health services. And in fact, for target 3.8.1 of the Sustainable Development Goals is on coverage of essential health services. And this is the key to attaining universal health coverage. So what I'm trying to indicate is that we need to talk about need to ensure that there's universal health coverage and there are no disparities, because this is the most important agenda in the Sustainable Development Goals. We can move to the next slide. So, and to justify why I say universal health coverage is key to Sustainable Development Goals, because we can see that for the goal number 10, it's all about reducing inequality within and among countries. So the Sustainable Development Goals, they're all about reduction of inequalities. And this is articulated explicitly in some of the goals, as I have shown here. Goal number 10 is reduction of inequality within and among countries. Goal number 1 is to end poverty and ensure that no one is poverty-stricken. Goal number 4 is to ensure inclusive and equitable quality education. So it's all about equity or equality, including in healthcare services. We can move to the next. In addition, we do have goal number 5 there, where it's all about to achieve gender equality and others. The third one, to ensure health lives and promote well-being at all ages for every individual. And this is why it becomes important to use an equity lens whenever we're looking at access and utilization of health services, including maternal health services. And the UN 2030 Agenda for Sustainable Development Goals aspires that no one is left behind. And this is why I have been compelled that today we talk about maternal health services using an equity gauge. Okay, let's talk about the Zambian context, and I would like to show you what's happening before I talk about existing inequalities. Let me talk about some of the issues that we have been facing as a country. So over the past couple of decades, we have seen significant progress in regards to reduction of mortality rates. For instance, maternal mortality ratio has declined from 229 per 1,000 live births in 2002, and then to about 278 deaths per 100,000 live births as of the latest Zambia Demographic Health Survey. So you see that there's been significant difference. I mean, even if this is a very good report on the reduction, I want to mention that within Zambia, the pattern is different because health disparities are existing, and these are based on residence, socioeconomic status, gender, including sub-regional. We can move to the next. I'm going to talk about the coverage and disparities of maternal health services by wealth, by residence, and by region over time, and show you how the pattern looks like for us to see what progress the country has made. So we can move to the next slide. So I'll start by talking about antenatal care visits. According to the World Health Organization guidelines, coverage, I mean, every woman should be able to seek care when pregnant within the 14 weeks of pregnancy. Not doing as good as urban areas over time, rural areas than urban areas that we historically know to be better than the urban areas. Now, on my right side, this is an equiplot trying to show the gaps that are existing between the rural and urban areas. And as shown on this slide, you see that while in 2007, the gap for coverage for women who came for antenatal care within the 14 weeks, while there was no difference because it was minimal with the rural areas doing slightly worse than urban. Over time, in 2018, we are seeing that the gap is growing, doing as better as rural areas. We can move to the next. So this slide really is trying to show how Zambia has progressed over time with the urban areas being left behind. We can move to the next slide. So the next slide is to show the disparities across the different economic or wealth given. As usual, as we may know, most times we see that the poorest, the poor, are usually left behind because of the challenges they have with access to services. And this was the case in 2007, over 2 decades, I'm seeing the gap seems to be closing. And the most recent Zambia Demographic Health Survey is showing us that, in fact, the poorest and the poor are doing far much better, with their coverage being higher than the richest and the rich populations. And this is the trend that we are seeing over time, where the gap is becoming wider, where the richer and richest seem to be left behind because access to these services is not as good as the poorest. We can move to the next slide. So, okay, so this is about the disparities in regards to antenatal care visits within the 14 weeks, where I have indicated that, yeah, so this is a different slide. Great. So for this slide, it's trying to demonstrate the coverage of antenatal care by worth quintile and residence. So as you noted that the urban population seem to be having lower coverage over time than the poorest. And so, by the way, this analysis and these equiplots, so what we have seen over time is that within the urban areas where we think over time they are not doing well, another important observation is that the poorest are being left behind. While the urban areas are not performing well, within the urban areas, we still see that the gap is growing wider between the poor and the richer and the richest. So as can be seen, different from what we're seeing in 2014, we are not doing well in regards to closing the gap.
Sorry, Dr. Jacobs, can I suggest that maybe you turn off your video? It might improve the access, yeah, because we are having problems getting you. Oh, thanks.
Okay. Are you able to hear me now? Does that
yes,
sound
we can.
better?
Let's see how this goes. Yes, let's see how this goes. But yes, we can hear you.
Okay. Okay, thank you. So we can move to the next slide, where I would love to show you the patterns that we are seeing in regards to skilled birth attendance. So skilled birth attendance, according to the World Health Organization, every woman that is pregnant should be seen by a skilled personnel. And this is a personnel that has been trained in providing services during childbirth. So coverage for skilled birth attendance over time has improved in Zambia. The gap between rural and urban areas is closing nicely. However, the rural population are contributing more to this gap closure of the gap that we are seeing. As can be shown in 2007, the gap between the rural and urban was quite wider, where only a third in 2007, only 3 out of 10 women were able to get skilled birth attendance during childbirth, where 9 out of 10 of those in urban were able to get this care from a skilled birth attendants. But over time, as of 2018, with the recent, our most latest Zambia Demographic Health Survey data, we see that the gap between the rural and urban is closing, although it still remains wide. But this is just to show that the gaps in terms of access still remain within a country like Zambia, where we think we still have challenges. And then we have other populations or other groupings that are still disadvantaged. So we can move to the next slide, please. So for this one, okay. So this is the one I was talking about, the differentials between the rural and urban. I'd like you to see the next one that is trying to show us the differences in regards to worth quintile. So for this one, skilled birth attendance coverage by worth quintile over and within the urban areas, as you can see that while we saw massive or significant improvement among the rural communities, although they are still lagging behind. In regards to worth quintile, we see the richer and the richest seem to be the ones that are accessing the services more than the poorest. However, we see that over time, compared to 2007 to 2018, the gap between the poorest and the richest seems to be closing over time. Within the urban, within the richest that we think, within the urban areas that we noted that they seem to be doing well, we have also seen over time that within these groups of people in the urban areas, we still have groupings that are being left behind, and these are the poorest. Although in urban areas, we do have access, radius for health service seems to be better compared to rural areas, but we still see a challenge where the poorest seem to be less likely to access the services. So this is another slide where I wanted to show you the patterns in regards to maternal health care services and the existing disparities that we see in regards to access to services. We can move to the next slide. So for this one, again, postnatal care, every woman should be checked for her health within the first 2 days after childbirth. Coverage over time has really significantly improved. You can see that as of 2007, only 27% of women in rural areas were able to get this postnatal care after childbirth compared to those women in urban areas. But over time, over the past years, we see that as of 2018, wow, we see that almost 70% of women, 2/3 of women are able to access postnatal care, even if we see that they still lag behind compared to urban areas. But as can be seen, the improvement has been much more significant among the rural populations. We can move to the next slide. So the slides I've just shown you are to show the progress that the country is making in regards to maternal health care services. And I've done a bit of demonstration based on access to antenatal care services within the 14 weeks of pregnancy, skilled birth attendance, and postnatal care. And a quick summary from what I've just shown you is that we see that there's been significant progress, significant improvement, particularly among the disadvantaged communities who are the rural populations and the poorest communities. Now, I wanted us to talk about some of the strategies or some of the responses that Zambia has taken to ensure equitable health services for maternal health, particularly maternal health care services. So I want to talk about governance and policies. Over time, since 2000, Zambia has had some health sector reforms. And one of the critical health sector reforms has been to provide equitable access to cost-effective quality health care as close to the family as possible. This has been a national anthem in the Ministry of Health in trying to ensure that services are equitably distributed and accessed and they are cost effective. So this policy really has significantly, we think that has really contributed to the improvements that we are seeing, particularly among the poor populations or marginalized. But in addition, over financing, there's been a lot of multi-sectoral collaboration, particularly for horizontal programming, where we see partnerships partnerships including external donors that have been funding. Some of our funders have been DFID and Gavi in terms of immunizations. We do have CEDA. So there's been a lot of interest to support Zambia from external donors. But also we have seen partnerships between government ministries. One of the past years, I think the government that was there intended that some of the maternal and newborn health services could be managed by the Ministry of Community Development. And this was in trying to respond to the call of ensuring that services as close to the family as possible. But also I want to talk about service delivery. So in regards to service delivery, Zambia is one of the countries that has been championing the community-based interventions, and these include community health workers. Zambia has trained quite a number of community health volunteers, and these volunteers have been critical in supporting women access the services. Most recent and not long ago we have trained another cadre, and this is a community health volunteer called the Safe Motherhood Groups. So the role of Safe Motherhood Groups are to encourage women to get to the facility. They will not deliver a woman, they will not provide a service, but they will create awareness and encourage women to access the services. So these community volunteers have been critical in trying to respond to the call of ensuring that services as close to the family as possible. Most recent and not long ago, Zambia has also been training another cadre, and this one is called a community health assistant. This is a more advanced assistant with up to what we call Form 5 education, over secondary education, and they are trained in a number of primary health care services that they can provide. In these cadre, they get a minimal remuneration. And also, let me talk about infrastructure. The country has responded to the issue of infrastructure, one of the important health system building block. So, we've seen most recently where there were targets that and commitments made to say over 600 health posts would be built in the remote areas where services were thought to be a challenge. So the country has built an infrastructure or a facility that we refer to as a health post. This health post is able to provide at least the basic and important services to the communities. In addition, we have seen health facilities being built amongst the remote communities. Human resources, we have seen human resources trained, particularly midwives have been trained. And we think that some of these responses that Zambia has undertaken could explain the improvements that we have seen over time in regards to access to, in regards to coverage to maternal health services, including maternal mortality, as I had shown in the background slide, where we have had a significant reduction in mortality, maternal mortality. We can move to the next slide. And for the next slide, I just want to indicate that while we think that the responses that Zambia has taken could explain why we see the historically disadvantaged communities doing better and the progress accelerating at a higher rate than those that are seem to be more advantaged, there's still some challenges that I can talk about in the implementation of these so-called equitable health services. So one of them is health system related factors. Even if I talk about an increase in finance, this still remains a challenge because, as I indicated, most of the finance that we are getting are donor driven. And so when funds are donor driven, the funders, they come with their own agendas. And so this really becomes a challenge. And when some funding is pulled off, then it becomes a bigger challenge. For instance, some of the community health volunteers have been trained by some external funders, and when they train them, they give a lot of dropouts because some community volunteers are failing to sustain in the duties because of lack of funding. Such as midwives, the ratio between a provider still far to be desired. So the targets have not yet been reached. We still need a lot of training and a lot of training to be able to meet the targets. But let me talk about access. Access still remains a challenge. Individual factors. There's some individual factors where we're seeing the age of individuals. Evidence has shown that people are less likely to access maternal health services. They have the skill. Some evidence has also shown that the less educated are less likely to access the services because they are not able to compete. But also the socio-economic factors, those still remain a challenge, including the social cultural. We still have a lot of cultural beliefs and myths that really hinder access to services, because women may think getting to a facility or being delivered by a younger nurse is unacceptable. So we see that because of these challenges, has not reduced, unfortunately, the distance to get to the facility. And for the next slide, we can move to the next slide. So the case study that I'm presenting for the next slide, we can move to the next, is based on some work that I've done. So for this particular work, we're looking at the effect of implementation of a community-based intervention in a most rural and remote district of Zambia. So we selected a few districts that we have thought they were most remote and tried to implement community-based interventions. We can move to the next slide. So for the community-based intervention, and you can click again, another click. Okay, so for this one, what we did in this community-based intervention was to try and train community volunteers, such as traditional birth attendants, growth monitoring promoters, and the SMAGs. The idea was that once these are trained, they'll be able to support women to get to the facility. So these community health volunteers that were trained, they were meant to support women within the communities and bring them to the facility. And we thought that by implementing this intervention among the poorest and remote areas, that would improve access and coverage to healthcare services for maternal health. We can move to the next slide, please. So the assumption we had for this implementation was based on the logic inputs, processes, outputs model as a theory of change to guide this implementation. Some inputs funding was with support from UNICEF, was put in. Healthcare providers were trained as resources for supervision. Trainings were done, and ultimately we had trained staff, we had trained community volunteers, and we provided the tools they needed, the raincoats to be able to move out in the harsh weather. With all that was done, the target was that there would be increased coverage and that the behaviors of people in access to services would change. And ultimately, there would be reduced mortality in these communities. We can move to the next. And unfortunately, or fortunately, let me talk about fortunately, we certainly, after some time, we noted that there was significant effect on most of the maternal health care outcomes of our interest. We noted increase in antenatal care services. Women were more likely to go to the facility for antenatal care, for skilled birth attendants, and for postnatal. However, we also noted that while we were implementing this intervention in 4 separate districts that were all known to be remote and poor, we noted that there were variations. Some districts were not doing any better than the other. Some districts failed to meet the targets that we had aimed to. And the increase, even if I'm talking about it, it was just marginal. It wasn't as high as can be seen below there. For instance, for antenatal care, we had hoped that we'll meet the target in like the national targets of 80%, but we only met to 42. And this was same for the other indicators. We could not meet the targets. And you know why? We can come to the next slide. So for the next slide is to explain some of the challenges that we found. And this work was published in Implementation Research, Implementation Science Journal. I think it can be accessed. We can move to the next slide. So I will not talk about the objectives. So what we did, so before I tell you why we did not meet the targets and why progress was marginal, we tried to do, we did a study, a process evaluation to understand why the targeted key indicators, even after investing in some rural and remote areas, could not be met. And the design that was used, we used a process evaluation for based on the MRC framework. So let's move to the next slide, just to show the summary of the findings. So using this process evaluation, we wanted to understand why is it that after investing in these remote areas, training and providing the tools to the community volunteers, the targets were still not met. So the most important thing that we found was contextual. Context. The implementation context, the context in which you are implementing an intervention. While it may work in Malawi, that may not be so for a country like Zambia. So one of the contextual factors was the geographical barriers. Although we trained community volunteers that seemed to be the most preferred by these women and living within the communities with women, the issue of transport remained the same, because when a woman needed to go to the facility, even if the community health volunteer needed to take this woman to a facility, that did not shorten the distance. The distance remained the same. And so we saw that while we trained them, there are other factors that could not help in trying to, improve the coverage. And the other one was social cultural factors, the issue of gender roles, the cultural issues, the gender roles. Among some of the community volunteers that we trained were male. And for females, this was not acceptable because pregnancy is held some kind of sacred, and for a man to be the one to attend and to take the woman to a facility to attend to any complications was not acceptable, because we trained among the community volunteers females and males. But also the gender preference. Women thought they would rather be taken care by a fellow woman. And so we see that this became a problem. But also the community volunteers, even if we trained them to be able to support women and create awareness for need to get to the facility, these community volunteers are viewed as bearers of life and death within the communities. The trust that women within the communities hold for these community volunteers have remained even in these rural and remote communities. Women preferred to be taken care by the community volunteers because these are the people that they trusted. But also, I want to talk about another factor, which was the mechanism of impact, the personalized care. So we see that while these community volunteers were trained to support women to the facility, because of the poverty issues within these communities, the community volunteers found themselves going beyond their duty, the core of duty, because there were homes where they found that the woman had nothing to cover herself or would cover the baby if she was to go to the health facility. And so there was this issue aspect of the community volunteers going beyond their duty and addressing personal problems. And so this became a challenge they were supposed to. But finally, it's the issue of the processes, the services. Even if the community volunteers were able to take these women to the facility, we still noted that some facilities still did not have a skilled healthcare provider. At this time, some of the facilities did not have a provider. And so Some women did not see the need. While they thought they trusted this community volunteer, they didn't see need to get to the facility. But also there was an issue of equipment. The tools were given, but they could not be sustained. So we see that there's an aspect of sustainability with the tools that we give the communities. So these are some of the challenges that I could talk about based on this case study, the study that I undertook among the poorest or remote populations. We can move to the next slide as we almost conclude. So based on these findings that I'm in the scenario that I've shown you in the case study, we see that health disparities exist within countries. While we know that sub-Saharan countries and other low-resource countries are most disadvantaged, within the so-called disadvantaged countries, we still see disparities that are existing. And yet, the agenda for sustainable development goes towards 2030 is to ensure that no one is being left behind. And also, while efforts are being done by governments to ensure that there's universal health coverage, within populations, we still see that variations are existing. And also, just to mention that while community-based interventions using the primary healthcare model may improve existing disparities, contextual challenges are still existing. And so, however, the good thing that we are seeing is that despite all these challenges that countries such as Zambia are facing, one exciting observation is that the rural communities seem to be doing well. And we think that as a country, the approaches, the responses we have taken so far have really significantly improved, even if we still see the gaps that are existing. But more so, let me talk about the disparities that we are seeing in the urban communities, where we've historically known that urban communities are well serviced, they are better off than rural areas. We see that there's a lag there. And even within this the lag that we are seeing within the urban communities is because within the so-called urban communities, we still have some communities, some women that are still disadvantaged. And we have seen that these are the poorest. These are the ones that may not be well educated. And so we think that even in a city where I'm sitting currently, in Lusaka City, our other recent observations has been in a city like the capital city, we see that there's groupings that are still not accessing the services. To sum it up, I think that for us to improve the disparities that we are seeing, contextual specific interventions are important. Probably we need to refocus on how we approach in trying to address some of the challenges that women are facing. While we think women are facing challenges, probably there's need to have an equity lens, seeing who is being left behind. And when we are able to identify the people that are being left behind, interventions that are tailored to meet the needs of such groupings remain quite critical. And I think that it's time for governments not to ignore the urban communities, the cities that we think are doing well, because while we focus on the rural, we may be causing another gap within. And so this is the end of my presentation. And in ending, my message is context-specific interventions remain critical, and equity gauges remain important, and so should not be ignored even as we track progress towards the 2030 agenda of sustainable development goals. Thank you, and thank you so much. Bye.
Thank you very, very much, Dr. Jacobs.
Over.
Your voice is very, very clear. We can hear you. We can hear you drumming on context. And yes, the inequalities are very clear. Yeah, we have seen the technical glitches that we've had with internet. It sent me thinking, oh, these are different levels of inequalities. Our governments are able to assist us in those kind of areas. So At this point, I'd like to still to the participants, thank you so much for still hanging on with us despite the technical challenges with the internet. We still have our 26, 27 participants. If you have questions, still put them up in the question and answer section on the right-hand side. We will be taking the questions as the,
Yeah, shall I? There's a few questions that have come in. So shall I share those now?
Yes.
So there's one from Alison about is there any way that partners could help in addressing disparities in maternal and neonatal health services in Zambia? And then related to that, sometimes external donors want to introduce a program without doing an in-depth needs assessment to really understand what help is really needed. And I think you alluded to that. Is this a problem in Zambia for women's health?
Okay, so I'll respond to the first, and Emma, you could also zoom the next in case I forget it. But let me respond to the first question. Yeah, so we can have the question while I respond. So yes, external donors. There was a question to say, is there any way donors can support in closing the gaps, disparities? Yes, partners can help in addressing disparities. Yes, there is, and the need is there. The need is huge. But what type of help do we need? I think for me, the first one that is critical is support to be able to track progress and see who is being left behind. Most of our studies, most of our evaluations have not taken that lens to look at who is being left behind, when in fact this is very important. Evidence is very critical. Support to provide evidence on who's being left behind, whether in a small study or a big study, doesn't matter, because even a snapshot will give us an idea of what is happening. So evidence is critical, and support in providing this evidence on who's being left behind is very important, because that will inform interventions, that will inform our government. We have a listening government, and I'm confident that the evidence that we get, we are able to force our way and push our chair on the tables as the ministries of health are preparing their yearly budgets. And we think that if we have opportunity to get this evidence, we can take it to the tables as they plan, and that will inform the interventions that we plan for. But in addition, other than just providing provision of supporting research and evidence, I think that the other aspect would be support some of the community-based interventions that have been shown to work in other countries. We have a lot of case studies. Some interventions have been shown to work in other countries. But because we have insufficient funds, we cannot demonstrate that such interventions can be applicable to our country. Such support would really go a long way. I know there are many more, but I think those are the ones that I think would be critical. I don't want to talk about bigger ones, but if financially, I mean, there are so many interventions that we can talk about that can support in closing the gaps. As I have indicated, we are seeing that the urban communities in Lusaka City, some women are not able to access the service. And we are right here in Lusaka City. We mingle with funders, we mingle with everyone else, and yet our women are dying within the city. So I think that's a challenge, and we need support on that. Thank you. There was a next question, Emma. Are you able to?
I was going to. Tawera, did you want to ask your question? You said you had a question.
Maybe not quite a question, but just observing the important role that the community representatives are making. They are playing a huge role, and it reminded me of the tuberculosis directly observed therapy. Community members were involved to supervise as patients were taking treatment. So we see that works. So in this case, there's demonstration as well that community members do play a great role. And I was just thinking, as I saw the question to say, are governments seriously, like, do they have the desire to help, like serious desire to help? And I'm thinking the community is working, and could the government encourage that? Could the government support that? Are they able to do that?
Yes, yes, and you are right, Toela. The community volunteers are doing a tremendous job, but we have seen sometimes there's a dropout because they cannot sustain. They have their own needs. Voluntary work is not easy, and so governments may be willing, but I think this is another cadre that we may need additional support, if that may be. But these are some of the things we are advocating to the government to say, how best can we support these community volunteers? And in response, the government has trained another advanced cadre, the one I referred to as a community health assistant who is getting a minimal allowance. But we still have quite a lot that are on voluntary basis. And we hope that one day we'll be able to motivate these volunteers within the communities to be able to provide effective and quality health care services.
And that's just Tawera was referring to this question. Is there a real desire shown by your government to reduce maternal and newborn mortality and morbidity? Or, as with many countries, do they just pay lip service to it? It's quite a challenging question.
It's a challenging one, yes. The desire is there. The desire is there because we have seen the impacts that they have. But I want to believe that it's an issue of being a low-resourced country with all other challenging aspects that governments need to attend to. Yeah, it's a difficult question, to be honest.
Yeah, absolutely.
I wish I could come with a policy maker here to speak on my behalf.
I'm sure. We're running a little bit over time, but there's still a couple of questions here. Are you happy just to take those?
Yes, please.
Yeah. There's one about your community health volunteers. Do they get any specific training on how to recognise when a mother is sick or deteriorating? Late referral seems to be a major problem everywhere.
Yes, late referral is a problem. And so we have a basic package training that these community volunteers are trained on. They are trained on ability to recognize some of the danger signs. They may not be as accurate as a skilled birth attendant, but they are provided with a minimal package based on their level of understanding, because these are volunteers that may not have the adequate education to be able to conceptualize. However, they are trained to identify some of these problems to be able to refer women. And so we have a specific kind of cadre called the SMAG, the Safe Motherhood Action grouping. These are cadres that are trained in not only creating awareness on need to get to the facility, but also to be able to advise a woman when they need to go to the facility. However, in regards to identification of complications, they are doing their best, but probably that may be minimal as compared to a skilled care provider.
Great. Should we make this the last one? There's a question about the uptake. What's the uptake of telephone mobile like? Gifted mum and zero mothers die. And do they make a difference?
So yes, I've heard about digital platforms, and I'm sure this is what is being meant here. Digital platforms to improve access to services. Wow.
Yeah, sorry, apps, yes.
Yes, the digital apps. So no, apparently we do not have. Um, I want to indicate that most recent, I developed a concept in trying to see whether a digital app could be used in one of the communities where there are higher maternal deaths. And I drew that concept. Unfortunately, we could not get funding. We have seen that these work in other countries and they've been very useful. I'm hoping that one day we can demonstrate through, even if it's a small study, to show the effect of using digital apps in trying to improve access to healthcare services. That's something that's on my heart, and I hope that one day it will be a reality. And if we can demonstrate that to the country, probably this may change the patterns that we are seeing.
Great, thank you. Back to you, Tuera.
Thank you very much, Dr. Jacobs, for the insightful presentation. It's unfortunate that we keep seeing, like in Africa, a pregnancy is always a death sentence. You don't know if you're going to come out of it alive, if the baby is going to come out alive. At the same time, we do recognize the efforts that are being taken by the governments, even though they are inadequate, and the support, external support that we get from different donors, that will always be appreciated. I would like to thank our participants. Thank you very much, and thank you for the questions. I'd also like to thank the Hub Cymru Africa, Emma, Peter, for taking us through this. To everyone, please remember that you can join a table to carry on with the conversation. After this, you can click main stage brief. Other than that, I'd like to mention that our next presentation is at 2:30, and it's on anti-racism at home and in the partnerships. So the session will also introduce the Hub Cymru Africa Anti-Racism Charter. So that's exciting. Let's join if we can. Thank you very much.
Thank you, Tuera. I'm just going to quickly launch the polls before we go, and leave those up for a minute. Oops. Sorry, technical issues.
Yeah, as always. But despite the issues, IT, internet is helping us a lot, is helping us to get a lot of things done that ordinarily we would not have been able to do.
And it's fantastic to have Dr. Choolwe Jacobs here from Zambia without having to get on a plane.
Yeah.
Which is an amazing thing.
Reducing the carbon footprint.
In the week of COP26, it's good to be thinking about our carbon.
True, true.
Great. So I'm just going to we need to wrap up really, so I'm going to close the polls, but thanks everyone for that event. It's been really fantastic. Thanks to all the speakers and to Dr. Choolwe and Tuera for your participation. Excellent.
My pleasure.
Thank you.
Okay, thank you.
Bye.
Goodbye. Bye.
Bye. Bye. Bye.